Now, on the topic of problem identification, we've got a special reading for you, which is called Lies, Damn Lies, and Medical Statistics. And it's actually a magazine article about a doctor, Dr. Ioannidis, who wrote a very important paper about medical research and healthcare research in general, and how a lot of the medical research is just not very good. And part of it goes back to the types of questions that are being asked. If you're asking the wrong question, you're never going to get the right answer. And so what he did was he identified some of the ways that when we formulate our questions for medical and healthcare research, that if we're not careful, we'll end up setting ourselves up for failure. I mean, we might be successful in getting results that can be published, but we're failing to gain any real knowledge. And even worse, we can delude ourselves into thinking we know something that we don't. So that's going to be some of the foundational reading for this week, for this module, for this week, is we're going to read that article. And then we're also going to read one of Dr. Ioannidis' articles that he published in JAMA, the Journal of American Medical Association, about this problem. So we're going to get kind of like the popular media version, and then we're going to get his scholarly version as well. And so you're going to be writing a little journal reflection. So this is not a threaded discussion. Basically, I want to know that you've understood the basic things that he's proposing in that article. So you do not need to summarize the entire article to me. All you need to really do is let me know that number one, you've read it, and number two, you've understood it enough that you understand the basic point he's trying to make. So that is Dr. Ioannidis' background reading. So when it comes to problem identification, there's usually in healthcare research 3 aspects to a problem. So those 3 aspects are, number one, a population, which is typically a group of patients or a group of people with particular attributes. So it can be something like ICU patients. It can be patients who have HIV. It can be cancer patients. It can be very, very broad, or it can be very, very narrow. It can be by ethnicity, it could be by a common diagnosis or a common culture. I mean, but it has to be some identifiable group. So that's the first one, and it's often called the population. Now, if you talk with the statistician, they're not going to understand you when you say population. The word that they're going to use is the word universe. So to a statistician, population is a collection of measurements. So if you take blood pressures on those patients that you're interested in, that group of blood pressure measurements would be called the population to a statistician. But for the most part, everyone else you talk to, you can just say the word population and everyone's going to understand exactly what you mean. And chances are a statistician who works with healthcare people will too. He just might in the back of his head go, "You mean universe?" So if you want to impress your statistician, call it universe, but otherwise population. So the first part of our problem identification, the first part is a population. The second is a concept or a phenomenon. So it could be infection, it could be heart attack, it could be happiness, it could be self-control, it could be stress. We're trying to measure some sort of concept or phenomenon. Now, there's 2 parts to any phenomenon or concept, and that is the concept itself, and then it's how we measure it. So it's not enough to say, well, I'm going to be studying urinary tract infection. You actually have to define how you're going to measure it. So let's just do a quick brainstorm of all the possible ways that we could measure urinary tract infection. So the most obvious one would be a urinalysis. You could also do urine cultures. Now, what's the problem with doing a urine culture? Well, it costs more, there's a lot of room for contamination, and it takes a couple days to get back. So if you're doing research on patients with a budget, you might not be able to have in your budget the ability to do a urine culture. And in fact, urinalysis also takes money. So you might not have access to urinalysis as well, depending on your budget. So how else could you measure it? Well, one would be signs and symptoms. But we know that some patients who have infections are asymptomatic. Also, some of them may not be able to express those signs or those symptoms. So they might have dementia, they might be intubated, they might be at lower levels of consciousness, and that would impact the ability to express signs and symptoms of urinary tract infections. So another way you could do it is you could say, well, what if they have a fever or a high white blood cell count? If they have either of those, that'll be considered a urinary tract infection. And I know what you're thinking, but it could be a surgical site infection, it could be pneumonia, it could be all kinds of things other than urinary tract infections. And you're absolutely right. However, what's the number one infection in the hospital? Well, it's urinary tract infections. So what you'll actually see is a lot of research studies that are done retrospectively. That means that the patient's already gone. And so we're looking at, say, last month's data, and we want to know what was the urinary tract infection rate on our unit. Well, if we don't have urinalysis on every patient, and we don't have a urine culture for sure, and we can't go back and ask the patient how they feel, so all we can do is go by what's in the chart. And you know what's in the chart? White blood cell count and temperature. So that's what we're going to go by in a lot of research studies. That's what they report as a urinary tract infection. So if you're comparing two different articles, and Article 1 uses urine culture, and Article 2 uses temperature and white blood cell count, even though they're measuring the same concept, urinary tract infection, they could have extremely different findings, even if it's being done on the same population of patients. So the second part of our problem is the concept that we're trying to study. And in that, there's two components: the concept itself and how it's being measured. Now, I need to give a word of caution here, that a lot of times what a journal will do is, in its title, it's not going to say what the actual concept is. It's going to talk about a statistic related to the concept. So, for example, mortality. A lot of times what you'll see is, what is the impact of X on mortality in this population? So, mortality is not a concept that we measure. Dead, yes or no, is the concept that we measure. So is the patient dead? Yes or no. And the number of patients who died divided by the total number of patients is a statistic called mortality. So it's very, very important that we don't get too confused, because the right way to think about a journal article title is that it's a headline. And what is the purpose of a headline? It's to catch your attention. Hey, stop, look. So we're going to use emotive words. We're going to use words that sound good. We're not necessarily going to use words that are accurate, technically speaking. So when you see mortality, that's a shorthand for, we studied, was the patient dead or not? So what is the concept? Death. And how do we measure it? They were dead or they weren't. And then, so just be really, really careful for that. There's a lot of words that sometimes are triggers that should lead you to think, oh, that's what it really is. So another one would be morbidity. So morbidity, it means affected by the disease, and it's often defined as the hospital rate. So how many patients were in the hospital? Another one is incidence. Incidence is an epidemiological term meaning new cases of a disease. And it's usually defined as new cases of a disease within a 1-year period, but in your particular article, it may be referring to just new cases within the time frame of the research being done. So you have to be careful. Let's say it was a 3-month research time frame, or maybe it was a 2-year time frame. Are they calculating it out to a year, or are they dividing by the total amount of time in the research study? Another one would be prevalence, and prevalence is just the number of people who are affected by the disease at any given time. And so again, if you're looking at a research study that's being collected over time, how is prevalence being reported? Is it anyone who had the disease during that time, or is it anyone who had the disease during that time divided out so that it's a yearly rate? Those sorts of things are important to know. So statistics are not necessarily the concept, and a lot of times headlines and even article abstracts will say the statistic, and it's up to you to figure out what the concept is. So The first one was the population. Second one is a concept, and that concept is going to occur in the population. So the urinary tract infection occurs in patients in the ICU, patients in a hospital unit, patients in the outpatient setting, patients who have bladder incontinence, patients who have spina bifida. So that population, you're going to be studying the concept in those people. Also, we should probably note that the population doesn't necessarily have to be a person. So everyone has two eyes, and so the population could be an eye. And you could actually put one thing in one eye and one thing in the other eye, and so the population is an eye, not a person with two eyes. Does that make sense? If it doesn't make sense, shoot me an email or a text. The third aspect of problem identification is what we call factors or study factors. Sometimes these are called independent variables. Now, the whole idea behind independent variables or study factors is that these are things that could affect the concept that we're trying to study. I should also mention the concept we're trying to study is going to be called the response variable. So if I ask you to identify the response variable, for the examples we've been using so far, it would be urinary tract infection as measured by the presence of white blood cell count or fever during their time in the ICU. Okay, so there's our concept, there's our response variable. So study factors are things that could affect it. Now, let's say that I am a hospital administrator and I've got someone coming in a vendor coming in who's saying, hey, we have this newfangled cool technology that our Foleys are impregnated with this special antibiotic stuff, and it's going to reduce your incidence of urinary tract infection. So the study factor in this case would be our old Foleys versus these new Foleys. So if we adopt these new Foleys, are they going to change the urinary tract infection rate? Does that make sense? And again, going back to that idea of statistics, a rate is something you calculate based on measurements. So urinary tract infection, yes or no, the patient's got it. How do we know? Measured by. And then once you've measured them, then you're going to calculate a rate of infection. So what we want to know is, what is the relationship of our Foley catheter type, the old one or the new one, on urinary tract infection in ICU patients? So now we've got a problem identified that has three components: a study factor, something that is going to affect the next thing, which is the response variable, the concept that we're trying to study, in a population of interest. And that population of interest is where we're going to measure the response variable. So, if you're familiar with the movie Princess Bride, truly you have a dizzying intellect. Now, three things you got to remember. What are they? Population of interest, response variable, which is a concept and how it's measured, and then the study factor, which are the things that you are interested in studying. So, things that could potentially influence your response variable. Now, a lot of people have trouble sometimes identifying what's the response variable and what's the study factor. So we're going to try this little experiment in your head. If I say that there's two concepts that we could study in a patient, one is needle size and one is pain from injection. Would you say that the pain of injection influences needle size, or would you say that needle size influences the pain of injection? Whichever one you think does the influencing is going to be your study factor. Whichever one of those you can manipulate is the study factor. The one that you're going to observe, hopefully responding to your study factor, is the response variable. And sometimes, instead of calling them study factor and response variable, they're called independent variable and response or independent variable and dependent variable. So those are just alternative terms for study factor and response variable. In this course, I'm going to be using the terms study factor and response variable. Now, I keep saying study factor, and why is it important to know about study factor? Could there be another kind of factor? And the answer is yes. So, The other factors would be called extraneous factors. These are things that could influence the urinary tract infection that I don't really care about. I don't care about the time of the month. I don't care about the hand hygiene of the nurse who is taking care of that patient. I don't care about the hygiene of the patient that came before. I don't care about their gender. I don't really care about their age. The only question that I have right now is this new Foley going to be different than the old Foley? So everything else that can possibly affect urinary tract infection, in this case, I don't care about, therefore it's extraneous. Now, good research is going to anticipate extraneous factors, and it's going to try to control for them. If research does not control for extraneous factors, you can run into a problem. And this problem is called confounding factors. So if you run up into a point where you don't know, well, is the reason that there's a difference in urinary tract infection because of my new Foley, or is it because the nurses that month did a really horrible job of washing their hands? Was it because of our new Foley, or is it because the patients in the new Foley group, the ones who got the new Foley, were much sicker or were more immunosuppressed than the ones who got the old Foley? So if you can't tell the difference because of an extraneous factor, then that's called a confounding factor. So the purpose of asking really good questions is not just to identify the three things we want to know. It's also to identify the things that could affect our answer that we don't care about, because we have to control for those things. So in the readings for this module, I've given you a couple exercises that you can do to kind of walk through this process of thinking through a problem, and then thinking through how would we define those things, and then eventually coming up with factors and extraneous factors.